Nursing Case Management, Congestive Heart Failure by Shauna Priest, Joy Martin-Spriggs, and Kelly Murphy. Patient and chronic illness. DS is a 68-year-old Caucasian male hospitalized for a congestive heart failure exacerbation. DS presented to the emergency room with shortness of breath and complained of increased peripheral edema. He has been married to his wife, MS, for over 50 years and has 3 children who check up on him periodically. DS is a retired auto mechanic and would be considered to be of middle-class socioeconomic status. He is also insured under Aetna insurance. DS was initially diagnosed with heart failure last year. In addition to this diagnosis, he has the following chronic conditions: hypertension, type 2 diabetes, arthritis, gout, morbid obesity, and high cholesterol. DS will be going home with the following medications: metformin, atenolol, hydrochlorothiazide, and simvastatin. In addition, he has been instructed to continue checking his blood pressure daily, apply compression stockings, and will have supplemental oxygen. He is to continue taking a daily weight and highly encouraged to adhere to a strict sodium restriction of 1.5 grams or less a day and a fluid restriction of less than 2 liters per day. In addition to this medical diagnosis, DS has the following applicable nursing diagnoses: deficient knowledge, fluid volume overload, decreased cardiac output, impaired physical activity, self-care deficit, chronic pain, ineffective tissue perfusion, and activity intolerance. The nursing diagnosis most pertinent to his case management needs would be deficient knowledge, and his nursing case management strategy or intervention would be providing patient education relating to adherence to dietary restrictions of sodium and fluid. DS will receive telehealth monitoring and continued education services with a nurse educator bi-monthly upon discharge. According to Larson, telemedicine interventions for CHF clients has been shown to reduce number of nursing visits, improve patient perceived quality of life, and decrease home health care costs. According to Orum's theory of nursing as cited by Allspach, self-care can be described as, quote, comprising all of the voluntary activities that individuals undertake in order to maintain their health, life, and general well-being, unquote. DS has the capacity to complete certain aspects of his self-care, but also lacks the ability, education, and motivation to complete others. Self-care behaviors focused on his congestive heart failure exacerbation and chronic disease include medication administration, compression stocking application, elevation of his lower extremities, weight monitoring, sodium and fluid restrictions, dietary compliance, appointment management, and oxygen monitoring. DS has been successful with most aspects of his chronic disease management, but has been non-compliant with dietary aspects of his self-care and has not been monitoring his weight or adhering to fluid and sodium restrictions. Measuring the capabilities of an individual's ability to perform his or her activities of daily living, or ADLs, can be an indication of degree of disability with his or her disease. DS currently has high functionality with the majority of his basic ADLs, or activities of daily living, and is having increased difficulty performing IADLs, which are his instrumental activities of daily living, such as grocery shopping, cleaning, and performing yard work. DS receives functional care assistance from his wife and children in those particular aspects of his care. Some of the barriers identified to DS's self-care capacity are behavioral, while others have the potential to improve with increased resources and education. According to the Agency for Healthcare Research and Quality, quote, discharge from the hospital to home requires a successful transfer of information from clinicians to the patient and family to reduce adverse events and prevent readmissions, end quote. The ideal discharge planning model is endorsed by the AHRQ and used to help engage patients in their care. We can implement the system to identify priority areas for discharge planning with DS. Under I, we're going to include DS and his family in the discharge planning process. We will ask some questions and identify their needs and concerns about transferring to the home setting. Under D, we will discuss the key areas that put patients at risk for readmission. These include asking DS and MS what their daily routines include. We will also review their medications and make sure he understands that what each medication is for, when to take them, how to take them, and when to report side effects to his nurse or doctor. We will also go through key warning signs and symptoms of CHF that warrant immediate physician notification. We will go over pertinent test results and schedule follow-up appointments with his cardiologist and primary care physician. We will also make sure DS knows when his telehealth appointments are and how to get in touch with his case manager, nurse educator, and any additional needed resources. We know that DS has had issues with dietary compliance, so ensuring that he remains on target with the goals that we set upon discharge will be our primary concern. Under E, we're going to continue to take every opportunity during his hospital stay and encounter with DS to go over his prognosis, discharge process, and what the next steps of his care are. We're going to continue to educate, which is the key component of this stage. Under A, we're going to assess and utilize the teach-back method to see how well nurses and doctors have explained DS's condition, prognosis, and discharge instructions. If needed, we can provide additional teaching and resources as needed. And lastly, under L, we're going to listen, and we're going to honor DS's goal for care, his preferences, and his concerns.